So our speaker today, Dr. Nikita Singh, is an intensivist and critical care clinical scholar at the University of Alberta. She received a bachelor's in biological sciences with philosophy minor and MD at the University of Alberta before completing internal medicine and critical care training at the University of Toronto. Dr. Singh's scholarly work lies at the intersection between social advocacy, the health humanities, and medical education. She is currently completing a Master of Sciences in Bioethics at Harvard, exploring how sociocultural contexts shape patients' and families' experiences of critical illness. During her free time, she loves reading, traveling, and cheering for the Edmonton Oilers. Without further ado, I pass it on to you, Dr. Singh. Thank you again for being here with us.
Thank you, Dr. Van Manen, and thank you all for joining today. I was reflecting with Michael and Carol that it feels like a very full circle moment because when I was a first-year medical student back in 2015, my first experience with the John Doster Center was as ethics representative for my class. And joining the clinical ethics committee at that time had really fostered my passion for bioethics. So I'm very grateful for the opportunity to be back home and to present today. I will be talking about cross-cultural communication during critical illness, which I hope to convince you is a matter of bioethical relevance. Just trying to advance my slides here. Thank you, Dr. Van Manen, for the land acknowledgement. I won't repeat myself here then, but I do wish to concretely connect my talk today to two of the calls to action in the Truth and Reconciliation Commission. There are 7 health-related calls to action. One of them is to acknowledge the use of Indigenous healing practices in the treatment of Indigenous patients. And call number 24 is about skills-based training in intercultural competency, conflict resolution, human rights, and anti-racism. So I hope that our talk today touches on these aspects of the Truth and Reconciliation Commission and concrete actions we can take towards improving care for our Indigenous patients. I would like to acknowledge Rami Anik, who I see is here with us today, who's one of my instructors at Harvard University, who has been incredible in helping support bioethical learning and content development here. And Dr. Lisa Richardson at the University of Toronto. Some of the earlier iterations of some of this content had been done to facilitate academic half-day training for internal medicine residents. And she's an Indigenous physician herself who does incredible work in this realm. I have no conflicts of interest to disclose. And without further ado, I'll get into my objectives here. One, to describe bioethical considerations in cross-cultural communication for patients and families experiencing critical illness. I will focus on the period of critical illness and end of life, but I do think that there are a lot of intersections with medical care in general, no matter what kind of temporal period you're looking at. To explore how cross-cultural communication underscores barriers to care that threaten health equity and justice, and to discuss strategies for fostering cultural safety, particularly in the critical care environment. A few disclaimers. This is not an expansive outline of inclusive medical practice, although a lot of those concepts do overlap, and I will touch on that. It is not intended to be a discussion of particular differences between cultures. The goal is not to think, I see a patient that looks like X, therefore I should do Y. It is instead to look at global principles in providing culturally safe healthcare, but of course you need to take a look at the particular context of the patient and family in front of you. And we will focus more on sociocultural considerations during critical illness rather than the structure of what goals of care conversations themselves look like, which is a whole other topic. So in terms of a roadmap, we'll start with what is culture? How does that relate to medicine? A lot of this content will be rooted in the social sciences and humanities, which I feel is the field of scholarship that best addresses those questions. Then we'll look at bioethical frameworks in the context of communication, followed by evidence highlighting the intersections between critical care and health equity. I know in medicine, we love evidence-based medicine, especially my colleagues in critical care. So I'm hoping to connect these links between the social sciences with evidence we have about our critical care patients. And then strategies for fostering cultural safety in the critical care environment. What can we actually do at the bedside and in the way that we communicate that can improve our patients' quality of care and health outcomes? So first, I would start with, I keep using the term cross-cultural communication. What is culture? How does this impact our practice in medicine? If you go to the actual dictionary definition, culture refers to customary beliefs, social forms, material traits that unify a social group. And this term social group will come up a lot in the humanities literature. It also relates to shared attitudes, values, goals, and practices that characterize an institution or organization. And so when we talk about culture in critical illness, it relates to our personal upbringings and backgrounds as healthcare workers, the backgrounds and lived experiences of our patients and families, the norms of the particular ICUs in which we work. I'm sure anyone who's worked in multiple ICUs can see just within the same city, you will see differences in how care is done or what the norms of a particular environment are. And it also relates to who we see as the default or standard versus the other, which we often do without even realizing. So, common pitfalls when we refer to culture is one, only thinking of culture as it relates to other people. Often I find we talk about culture in our conversations or on rounds only when there's a perceived difference or conflict, and not identifying how our current or personal contexts are impacted by culture, which is ongoing and an evolving process. So one example I use to highlight how culture underscores kind of everything that we do in intensive care is this BMJ article came out in the winter of 2024 called Demedicalizing Dying. Medicine must accept death as a natural part of life. And what's interesting is this article basically goes through how over the last centuries, culturally, death has been viewed more as a medical event, no longer a religious or spiritual one, with increased urbanization, being away from rural life, not seeing animals die on the farm, not seeing your grandparents die at home, for example, has culturally shifted the way we see dying. Um, and death is increasingly seen as a failure rather than a natural stage of life. So I thought this was really interesting example of how societal shifts about dying impact the work that we do in critical care. And this may not necessarily relate to cultural differences between us and our patients or families, but just an example of how historical shifts in time impact culture and the way we do our work. In terms of structural forces, the New England Journal of Medicine a few years ago started this series called Case Studies in Social Medicine. And I talk about a return to the arts here because I do think when we're talking about cross-cultural communication, there is a whole host of scholarship in this realm in the humanities that often we as clinicians may not have experience with, especially if our training is rooted in the sciences. So the point here is that I think theories of culture have traditionally been described through the social sciences and arts. Utilizing an interdisciplinary approach can enhance our understanding of multiple disciplines. And bioethics as a field has multidisciplinary roots. It's one of the things I love most about it is that we have philosophers, clinicians, people from different scopes and walks of life, lawyers. And so many of these principles overlap with the work that we do. So, the illusion of objectivity, this quote from a Lancet editorial, reflecting on these biases can be difficult for professions like science and medicine that are grounded in beliefs of their own objectivity and evidence-driven thinking. As I started by saying, I think we love evidence-based medicine in medicine. It's important, it's essential, but we can fall into the trap of assuming that the work that we do is objective. Biases are not bad, everybody has them, but without interrogating them, we run the risk of losing access to a whole host of information that impacts the work that we do. So this article by Sandra Harding was the one article I would say in all my undergrad most changed the way I see the world. And she argues here that if dominant groups, so your dominant groups in a given society, do not think about how they're losing access to information from people on the margins, it actually makes them less objective. So the paradox here is that in accepting our biases, interrogating them, and acknowledging where the limits of our viewpoints are, we actually open ourselves up to more perspectives and access more knowledge, which she calls stronger objectivity. So how does this all relate to our work in the ICU or in medicine? Medicine and the sciences, like all fields of thought, are influenced by historical and temporal context. The people who work within medicine are individuals with their own biases. As I said, identifying those biases paradoxically empowers us to be more objective. But being aware of those biases are not the same as behavioral change. And what I think is that we need to be actively engaged in trying to understand the lived experiences of others. So, why is communication a bioethical issue? So, cross cultural communication inevitably intersects with other axes of structural disadvantage, for example, race, migration, or language discordance. All of these are shown to impact health outcomes, and I'll go through some of that evidence towards the end of my talk. Health inequity compromises the principle of justice, which there are lots of definitions of justice, but Beecham and Childress will describe as fair, equitable, and appropriate treatment in light of what is due or owed to affected individuals and groups. And I think the point to highlight here is that our populations who have been structurally disadvantaged are likely to be owed different things than our groups that have more privilege. And so it's important to consider that equitable care doesn't look the same for everyone. Communication, particularly during heightened periods of acuity like critical illness, can significantly impact trust among patients and families with a history of structural disadvantage. And something I hope to kind of highlight throughout the talk is that often a lot of this mistrust has built before you've ever interacted with the patient or family in front of you. And it can feel very personal when you're in that conversation one-on-one. But it is important to consider the historical context and the things that people carry into the conversation, even if it had nothing to do with you originally. And surveys of bioethical consultants consistently show that many bioethical consultations include some overlay of communication challenges. So now that we've talked about what culture means and how it relates to medicine, what is cultural safety? Now, you may have heard of these terms before, and there are some subtle differences that are important, I think, to go through. Cultural sensitivity relates to perception, how aware you are of similarities and differences in cultural beliefs or practices between people and patients. Cultural competence, we have an asterisk here for a reason, is about the acquisition of knowledge. And this term has fallen out of favor because I think we all acknowledge it's not possible for all of us to become culturally competent in every culture. And I don't think that should be the goal. Our goal here is to seek to consistently and in an ongoing way understand and seek to um, look at the perspectives that our individual patients and families bring, but that doesn't mean we're going to become experts in their cultures. So that is what cultural humility refers to, ongoing self-reflection, and cultural safety really refers to respect and empowerment, to create an environment where patients and their families feel that their culture and knowledge has been acknowledged, and is integrated into a part of their care if that's what they wish. So I've just talked about this here, this idea that cultural competence is not really possible. And using the term competence can actually sometimes lead to us overestimating our understanding of other cultures. And so that's not the goal. The goal is ongoing humility and to foster safety through just having basic curiosity and a goal of understanding and meeting our patients and families where they're at. So, to next delve into the bioethical specifics of cross-cultural communication, I'd like to use our moral imaginations to think of the following situation. Imagine that you are the 19-year-old granddaughter of an 84-year-old woman admitted with a large bowel obstruction complicated by septic shock. The patient is now admitted to the ICU, intubated, and in multi-organ failure. As the only person in your family who speaks English, you are accustomed to providing medical interpretation. However, you are finding it very challenging to interpret the medical team's concerns about your grandmother's prognosis while navigating her critical illness yourself. You don't know how to tell your elderly grandfather that his wife is likely to die. Now imagine you are the 84-year-old woman admitted with a large bowel obstruction complicated by septic shock. You wake up to find yourself in significant amount of pain, unable to speak with a tube down your throat, with no idea where you are. You see a member of the healthcare team who speaks with you in English. You try to gesture with your hands that you're in pain. A few minutes later, your hands are restrained and you remain confused as to where you are. This process repeats again tomorrow morning. And third, you are the 86-year-old husband of the patient admitted with large bowel obstruction. You are devastated seeing your wife in this state and cannot understand how she's gotten so sick so fast. She was walking, talking, and joking with you just a few days earlier. The medical team provides updates every day, but you don't understand any of it. You ask for updates from your granddaughter, but notice she seems overwhelmed. She tells you that everything is going to be okay. You're afraid that your wife is going to die. So, if we take this scenario and the three characters in this story, traditionally, principlism is the framework in bioethics that has been really dominant. And the ideas behind principlism are that basic principles serve as a starting point for guiding ethical decision making. Principles are thought to be universal, including across cultures. And the term specification and balancing are used when principles are in conflict with one another. For example, if beneficence and non-maleficence are in conflict, you would go through a process of reflecting on which matters more and why. If we use this approach in looking at this case scenario, in terms of autonomy, we don't have a clear sense of the patient's underlying values and how she would articulate her goals of care in this situation. From a beneficence standpoint, there's a tension in wanting to support the patient and acknowledging concerns about her overall prognosis. And in terms of non-maleficence, language discordance is impacting restraint use in a patient who is already at high risk of developing delirium. We know delirium is independently associated with higher mortality in ICU patients as well. Justice. Cross-cultural factors in this setting, namely language discordance, are impacting the quality of care that the patient and her family are receiving. Now, I would argue that in this setting, I think a narrative approach to ethics would actually help us better elucidate the issues at hand. Narrative ethics is probably not talked about as much as principlism is, but is the idea that the morally salient features of an ethical situation arise in understanding the patient's story and its components, including voice, characters, and plot. Where principlism looks at abstract principles, narrative ethics favors what we call priority of the particular, and that means utilizing case-specific context to understand the ethical issues at hand. And I think when we are rounding in the ICU or seeing our patients in medicine, this is intuitively what we're more likely to do is to look at the individual patient in front of us and look what's impacting their world and their experience of their illness. I think it's less likely that we go around and think in terms of those four concrete ethical principles, although that may be what you do. Now, Martha Mantello kind of revolutionized narrative ethics in medicine and says that ethics consults often focus on the question of what to do rather than the question of how we got here. And talking earlier about the things patients and their families carry into these experiences, it's important to consider the question of how. And through understanding the how, we may better understand how to proceed forward or reach the narrative resolution. Now, if we use a narrative ethics framework for a patient's case, we would understand that the patient's ability to narrate has been compromised in multiple ways. She's critically ill, unable to speak physically, and is not being spoken to in her primary language. The dynamic between her family members, who are experiencing crisis in different ways, is impacting the next steps for her care. And the patient's granddaughter is struggling with being put in the position of relaying bad news to her elderly grandfather, which would not be the case if they all spoke the same language. The patient's substitute decision maker, her husband, has not actually received a medical update that he understands, which we would not consider to be standard of care otherwise. And there is a disconnect between the patient as her family knows her and the circumstances they find themselves in now, which leads to one of my favorite terms, which is peripeteia. This is a term Aristotle had coined in poetics, which often refers to plot in stories, but I think relates a lot to what our families and patients experience in critical illness, which is a sudden reversal of circumstances. All of a sudden, there is this critical event that completely changes your life and your world as you know it. And what for us is a regular day in the ICU is a crisis point for patients and their families. I think just acknowledging that is really important in terms of how to bridge the disconnect that can sometimes occur in cross-cultural contexts. So, in terms of our bioethical frameworks here, principlism and narrative ethics can be utilized in concert. We can see how certain ethical principles are compromised in our patient's case, but also appreciate that understanding the narrative here provides case-specific context that is important to communicating with her family. And to the narrativist, this communication is essential. So, this is a question I'm fascinated by, which is how do we center the voice of a patient who cannot speak? This is often the case for our critically ill patients. They physically cannot. You add an additional layer of language discordance where the patient and family may not actually understand what's going on. And all of a sudden, there are all these different facets that overlap to compromise the narration of a patient and their story. Shale Rawal is an internist in Toronto who does amazing work in the world of language discordance. If you haven't read this piece, I would highly recommend it. It's called The Right to Narrate Reflections on Language, Race, and Migration. And she asked this question of who has the right to narrate, that we live in really linguistically diverse cities in Canada, and in many hospitals, interpretation services are available but underused. A patient may be admitted and discharged without ever speaking to a clinician in their preferred language. We attribute this to language barriers, and by doing so, naturalize inequities in our institutions. And so it's important to interrogate how physicians and institutions act as listeners. It demands we consider how language barriers are constructed so we can determine how they might be dismantled. And she also acknowledges that language is tied to racism and nativism in medicine too. And so to reimagine our institutions, we need to enter into a true dialogue with those who we care for. So, though starting off with a discussion of what culture means, how it relates to medicine, and the bioethical frameworks, I'd now like to tie all of these principles and concepts to evidence about how sociocultural factors impact outcomes and mortality, including in the ICU. So, language discordance, I've used this term. What it's defined as is the patient and their clinician sharing proficiency in different languages. In the ICU, we have evidence to confirm that language discordant patients are more likely to be restrained and become delirious. And patients with language discordance are more likely to die with higher intensity of care and less likely to access palliative supports. Some of the explanations that have arisen in the literature are delayed clinical presentations due to partial understanding of medical context, potentially lower trust in healthcare teams. As I said, a lot of this can overlap and intersect with other aspects of structural disadvantage like racism. And here are some citations here. Some of these include work with patients in Canada. In terms of what we can do about this, the standard of care really is to use interpretation services. Often we use family and friends at bedside as interpreters, but there are more errors of omission and filtering of information, understandably, and it puts family in really difficult positions of trying to relay bad news, as we see in our case example, often with an element of a power difference to looking at your family dynamics. On the flip side, in a more positive way, there are improved healthcare outcomes with patient-clinician language concordance, including lower mortality. So if you pair an ICU patient with a nurse who speaks the same language, for example, you have made a big difference in that patient's care. There is a misconception that utilizing interpretation services takes longer, but interestingly, there was a study that looked at family conferences with interpretation and found that concerningly, they actually involved less time, support, and information. So, if anything, we should probably actually interrogate how much time we devote to ensuring care is provided in a patient or family's language of preference, and to consider that what we do by default rather than using family members as interpreters. I'd also like to talk about racism, which I think inevitably becomes part of the sociocultural context. I have focused specifically on anti-Black racism and anti-Indigeneity, as these are the two patient populations in Canada that do have higher risk of mortality just by stepping foot into a hospital. Although there are some overlaps with other cultural and racial communities as well. And I think important things to highlight here are that race is often confounded as a risk factor for poorer health outcomes when really communities are disproportionately impacted by other structural problems, for example, poverty. It's important to reframe racism as a risk factor, not race itself. There's a difference between the way people are treated based on their race versus the biological differences that are sometimes assumed to be the case, but not actually. It's also important to understand how particular histories impact the racism communities experience today, which is why cultural safety is so important, and that societal stressors often exacerbate existing inequities, which we saw during the pandemic. Brown and Black patients were more likely to die from COVID. It is also crucial that we don't only talk about this in terms of weaknesses, but also highlight the strength of community, which can be protective. And I'll use examples of that later. And I don't mean to glaze over this. This is by no means an exhaustive account, but meant to highlight that there are particular histories. Again, going back to the things that patients carry before they ever meet you in the ICU. The role of health systems in perpetuating these injustices impact the conversations we have with patients and their families today. So the Lancet back in 2009 had published an overview of Indigenous health across the world. And I thought this point was particularly salient and important to keep in mind when we're having goals of care conversations that worldwide Indigenous populations are young with proportionately fewer elderly people. And so when we're talking about potential de-escalations of care, stopping treatments, or being less intensive with our care, we're often talking about this with younger patients. And when they do have a history of medical related racism and trauma, this can be especially triggering and challenging for family members to navigate. There was a systematic review that came out in 2022 looking at racial disparities in ICU outcomes, which did note a higher mortality among Black patients, which was no longer seen when controlling for confounding variables like severity of illness, which I'll talk about again shortly. Black patients, concerningly, were more likely to have financial impacts during their ICU stay, less likely to receive an early trach, and more likely to, or less likely to receive timely antibiotics, which is all very concerning. So when we look at racial disparities at end of life and how this again relates to bioethics, many studies show differences in patients' end of life care. Critically ill Black patients are more likely to die with higher intensity of interventions at the end of life. They have lower rates on quality of dying scales when evaluated by their family members after death, less likely to have advanced care planning, and less likely to access palliative care supports. Interestingly, similar with our language discordant patients, if there's race concordance with their clinician, there's also a signal of a mortality benefit, which is really interesting. And all my citations here are Canadian studies. So I think often we think that that might be something that happens in the States. It is borne out in Canadian literature too, and important for us to acknowledge. So, knowing what this evidence highlights to us, how might social histories or structural disadvantage shape goals of care conversations with patients and families in the ICU? I think it's important when you're engaging in these conversations with the patient and their family to reflect on whether their history does include systematic marginalization, whether you should use interpretation due to language discordance. Does that history explain a mistrust of the healthcare system because of its role in perpetuating historical and ongoing injustices? And does your patient or family come from a population that has a higher risk of dying or poorer outcomes when engaging with the healthcare system? All these sociocultural contexts, which relate to cross-cultural communication, even if seemingly far removed from a clinical encounter, may be reflected in your conversation. And I have a little disclaimer here, caution in extrapolating one population's experiences to others, which again is an example of the priority of the particular and making sure that while we carry an understanding of all these facets that can impact people's care, to make sure we also look at the particularities of the individual patients and families we're speaking with. Crystal Brown is a researcher in Washington who was a visiting professor for us in critical care last year. I miss getting to see her, but I've spoken with her, and she does really amazing work looking at intersections of race with bioethics and critical illness. And what I love about this study that she did here is she actually spoke to Black patients who had experienced critical illness. And I find that there's often a paucity of research that relates to actually talking to people who have survived critical illness and asking them what their experiences have been like. And she sought to understand how racism may have impacted serious illness conversations and goals of care conversations for these patients while they were experiencing critical illness. And again, she acknowledges that Black patients experience higher intensity of care at end of life, and she wanted to understand why. So, really interesting themes emerged among these patients. One was that participants were more likely to trust physicians who recommended a procedure more than those who did not. So, interesting in terms of how we frame things might be more helpful to frame things as a transition to a different philosophy of care or treatment choice rather than stopping or de escalating. And patients were open to discussing end of life care, but many expressed difficulty imagining end of life care that did not consist of receiving life sustaining therapies. And I think the take home point here is that for this group of patients who had historically been given up on or mistreated by the medical system, they were more likely to perceive de escalations or less aggressive treatment options as giving up on them, even if that's what their medical team felt was overall better or more consistent with their goals of care. So again, here, this idea that they struggle to discern a clinician's recommendations to limit care apart from their role in a racist institution. I think my point here is that often it feels very personal if there's conflict that arises in discussions about treatment options or treatment recommendations. But when we look at the histories that people carry, this is the perspective that they bring to those conversations. So, from these interviews, there are certain concepts that I think can help us identify how we can frame our conversations with these patients. So, one, values and preferences stem from surviving unjust conditions and power inequities. There are challenges, as there often are for any patient, extrapolating from your current preferences to hypothetical future circumstances in critical illness and difficulty conceptualizing non aggressive end of life, with many voicing concerns that these therapies would be held because of their race. Deficit based frameworks that consider the white normativity to be the default also can lead to race being framed as a deficit rather than just one other aspect of a patient's demographics. In terms of what to do, trauma-informed approaches focus on compassionate, non-judgmental communication. I realize that can sound vague and sound like things that we already try to do, but there are specific things that seem to help. So, trust building before advancing goals of care discussions. Taking them in the first time you meet a patient and their family to ask about the patient as a human being, to ask about their values, what matters to them. It can take only a few minutes, but dramatically impact future conversations and impact the way those conversations unfold. I realize in the intensive care, often that's not possible if someone presents late or are already on the verge of death. But oftentimes it is possible to start with trust building first and to then advance your goals of care discussions later. Balancing power dynamics for patient empowerment is really important. So, having their community members around asking who they would want to be involved in those conversations and improving transparency in discussing these things. So, here again, this talks about personal values and preferences unencumbered by concerns of bias. And as I started saying, I think acknowledging those biases are important to be able to redress them. And again, here, interesting that race concordance for Black patients is associated with improved health and healthcare outcomes, including mortality. So there is something about that patient clinician dyad that changes when their provider does understand their cultural context. Earlier, I talked about the importance of talking about things in terms of positive aspects of culture and not just the potential downsides. Lisa Richardson and Alison Crawford had looked at COVID-19 and the decolonization of Indigenous public health. And had found that early in the pandemic, there were Indigenous populations that had lower rates of COVID that was related to the use of elders in distributing information about COVID-19. Um, and there's acknowledgement here about Indigenous self-determination, leadership, and knowledge playing a protective role for those communities. So, as often as we talk about how racial disparities and racism and all these cross-cultural impacts being negative on patient care, I think it's important to consider how doing things in a culturally safe manner actually have a very protective role and is empowering for patients and clinicians alike. So, how can we navigate these sociocultural factors and goals of care conversations? We started a bit of a discussion on that. There's a concept of two-eyed seeing by Mi'kmaq elders Albert and Merdina Marshall to reconcile Indigenous and Western ways of knowing, although I would argue that this can be applicable to any sort of cross-cultural encounter. The idea that these worlds of knowledge can be used together rather than be in conflict with one another. And I think we're very quick to describe encounters as difficult or to think about our frameworks as being in opposition with one another, but to instead look at how we can utilize these knowledges in concert can be very beneficial for patients and their families. In terms of strategies moving forward, I think when we look at how we present our patients' social histories and the language we use, reflect on are we feeling rushed when presenting the social history and why? I know, especially in the world of critical care, which is very fast paced, we present things very quickly, but I think just acknowledging something about the patient as a human and what their cultural context is doesn't take very long and can be very meaningful to patients and their families alike. Inquiring about their values, cultural, and spiritual practices. It's interesting. A few weeks ago, we did teaching with the Edmonton and Calgary Critical Care Fellows about cross-cultural communication. And one of the learners had asked about it feeling kind of othering to ask patients about their cultural values. And I think part of the reason for that is if we only do it when we consider someone to have a culture different than our own. So I would encourage us to do this kind of uniformly when we're doing our initial review of a patient or admitting them to take those extra few minutes to talk to them about their values up front. I would consider that an investment of time to save time later too, as it can, and qualitative studies looking at patient experiences too, say those initial um, moments with a clinician can drastically impact how things unfold later. Understanding what resources and supports are culturally important to your patients and families is important. And as I talked about here, a potential pitfall is only asking about culture for patients and families whose backgrounds are different from your own. Here I included some resources. Both the U of A and U of C have pages with culturally sensitive resources available. At the U of T, we had helped develop guidelines for inclusivity that includes resources that are also subspecialty specific within medicine as it relates to equity and justice in healthcare. The Truth and Reconciliation Commission, as I said, has 7 calls related to health, which I would strongly encourage people to review. There's a Royal College Indigenous Health Primer, and then the New England Journal's Case Studies in Social Medicine. I think oftentimes there's a tendency to dichotomize kind of the social aspects of medicine with quote unquote medical expertise, but I hope that kind of the studies that I've highlighted here have shown that when we do these things together, it actually provides patients optimal care and in some cases can have a mortality benefit too. Looking at presentations for patients, I found this interesting. So looking at the old kind of case presentations from the Mass General, this case is from 1971. And you can see up front that the patient's 20 years old, and the next few lines are totally devoted to explaining the patient's cultural context. Um, I don't know if it's nice to describe him as a sickly child, but he then delves into the patient's history being in a foster home, running away to California, his what precipitated the substance use that then leads to the patient's ultimate diagnosis. But it's interesting, if you look at these older cases, there was a tradition within medicine to center the patient up front and to talk about their social and cultural context. as you can see, it doesn't take very long, but it really does help contextualize the patient's narrative. These are the guidelines I was referring to. Just for the sake of time, I'll skim through them, but it also includes for if you're teaching your learners suggested case edits so that you're not accidentally stereotyping in an attempt to be inclusive. For example, not every South Asian person has diabetes, not every LGBTQ person has an STI. So there's some examples of how we can diversify our case examples for teaching without inadvertently stereotyping. And as I said, there's some examples based on your specific area in medicine and studies that might be more specific to your area of practice. So returning to our case, if we talk about the narrative resolution, you arrange a meeting with the patient's family, including interpretive services. By the end of your meeting, everyone has an understanding of the patient's critical state. The patient's husband is able to relay previous conversations he's had with his wife about critical illness. She would not want to live dependent on a ventilator and would value meaningful time with family at the end of life. Important to note here, I didn't cite the study here, but there was a study that showed that when a substitute decision maker is a spouse rather than a child or grandchild, um, the family is perceived to have a better end of life experience or quality of death or dying, which is often because people are more inclined to talk about end of life and their wishes around dying with their spouses than with their children or their grandchildren. Over the next few days, you work towards optimizing the patient for a one-way extubation. There's improvement in the patient's delirium with assignment of language concordant nursing and pharmacological adjuncts. The patient is extubated and transitioned to a comfort approach to care, and she passes away peacefully with her family at her side a week later. So to wrap up here, in terms of my take-home points, I hope I've convinced you that we can utilize scholarship from both medicine and the social sciences to improve care for patients impacted by cross-cultural communication, which also intersects with many other dimensions like language concordance, race, migration, etc. Narrative ethics as a framework can help elucidate morally salient features of ethical decision-making involving cross-cultural communication. With our case example here, you can see that strictly using principles may not actually elucidate the challenges each family member was experiencing, and what was key to actually improving her care and centering her values in this context. Understanding patient narratives is essential to trust building and improving equitable care during critical illness and end of life. And for that reason, health equity is a matter of justice. And I think this is why it's so important that ongoing qualitative scholarship does look at interviewing patients and families so that we actually have a sense of what their experiences are like so that we can improve their care the best that we can. And I'll leave you with this quote from Bell Hooks: to be truly visionary, we have to root our imagination in our concrete reality while simultaneously imagining possibilities beyond that reality. Thank you so much for your attention. I'm happy to take any questions, comments, or final thoughts. And if you would like to reach out, this is my email address. Thank you very much.